Go ahead and get started. My name's Elizabeth Biggery. I am the clinical outreach rep for Discovery Behavioral Health, which is recovery programs for three separate things. We have three separate programs. We have eating disorders, we have mood and anxiety, and we have substance abuse as well. So before I joined Discovery Behavioral Health, I was part of Fusion Academy, which we'll introduce them in just a minute. And I had worked with Dr. Ron and with Pam and with the hub and with Julie and Coach. And so we got together to collaborate to find ways that we can continue to support our community and talk about conversations around the brain and what we can do to empower all of us with more information to serve either partners or yourself if you're a parent or someone who's looking for more ways to have brain information. So each month we have a separate topic. Last month was Love Your Brain, and January was ADHD in the brain. And this month, which I'm really excited to hear the conversation between Dr. Turner and Dr. Ron about medication in the brain. So the four separate groups have come here together that are sponsoring the group. So I'm going to turn it over to Stephanie Alexander with Fusion Academy to talk a little bit about Fusion.
Thank you so much, Elizabeth and Dr. Ron. Yes, my name is Stephanie Alexander. I'm the new Director of Outreach for Fusion Academy. I work specifically with the Galleria and Sugarland locations, and we also have a location in the Woodlands. My counterpart piece works there. And so I'm very new. I'm a month and a half in. The nice thing about Fusion is that they are very welcoming and very understanding whenever you're learning the ropes. So I'm really excited to be part of the family and new to the role. So I'm very interested in learning about all of you and as well as the community that we serve. So I'm going to go ahead and introduce Julie Garcia. She is our new head of school and go from there.
I think Stephanie said all the wonderful things about Fusion and about our services for our students. I'm happy to be joining y'all as the head of school for the Fusion Galleria campus. Such a wonderful group of professionals and the services that you offer for our adolescents and the populations that we serve. So thank you for allowing me to be a part of this, and I'm excited to hear from Dr. Ron. Who's next? From one Julie to the next?
Yeah, we go over to Julie with the hub. Julie, go ahead and introduce yourself.
Hi, everybody. So great to see you all here today. And thank you to Fusion and Dr. Ron, et cetera, for putting on this amazing event. My name is Julie Pomerantz. I'm the admissions director for the hub. And if you don't know, the hub is an acronym for Heard, Understood, Believed in. And I'm actually sitting in for our absolutely incredible executive director and founder, Colleen Russo, better known as Coach, and she has another very important event going on today, so I am filling in for Coach. Very quickly, we've been open for about 6 years. I'll tell you three distinct programs. We do have a high school program. We can start around age 13 and go up to 18. Not all, but most of our students at the hub might fall somewhere on the autism spectrum. We also have students with anxiety or depression, Tourette syndrome, severe ADHD. Secondly, we have another program a mile away from our school called Life 101. And that is a program for those who are 18 and over. It's an employability program. We also can help with social skills, life skills, help them with their academic assignments if they are in college or a junior college. So that's all about helping that young adult population launch. And finally, the third program is called Club Hub, which is strictly social, 3 nights a week. That is also for the population of 18 and over. So thank you all, and I look very forward to hearing from Dr. Ron today. Thanks.
Awesome. Thank you, Julie. And now I'm going to turn it over to Pam with ADA.
All righty. Thank you, Elizabeth. Hi, I'm Pam Esser. I'm Executive Director of ADA Southern Region. We work with those with attention deficit and associated disorders. We have free support groups, and right now they're all virtual, so there's 3 per month. And then we have educational events. We were thrilled to have Russell Barkley in January, and I think we'll be doing another with him later in the spring. So we usually have an annual conference in February, so maybe next year we will be back at it. But we love working with this group, and we're really excited to be part of it. So glad everybody's here today.
Thank you, Pam. Okay, before I turn it over to Dr. Ron to introduce himself, I do have a couple housekeeping items. One, if you wouldn't mind putting your name and who you're with in the chat box down at the bottom. That way we can count your attendance. And when we send out the links and the video after this presentation, we'll know who to send it off to. So if you wouldn't mind, again, putting your name and who you're with down at the bottom in the chat box. We would really appreciate it. At the end of this presentation, we will have question and answer section. So if you do have a question along the way, feel free to also put that in the chat box. I will help moderate that and share that with Dr. Ron so we can answer your questions. We want to make sure you leave with plenty of information. So don't fret if you miss a note or two. Like I said, we will be sending out the slides and the video after this presentation. So I'm going to turn it over to Dr. Ron and take it away.
Okay, hang on.
One moment.
Intermission.
Intermission.
Thank you.
Well, some people are having difficulty figuring out the link, and I'm trying to register. Now I'm just going to send them the link, so I may have to give you my keyboard if any more of those things pop up. I'm Dr. Ron Swatzyna. I've been working in this area since 2003. Worked for the Tarnow Center for about 17 years, and then I got out on my own here about a year ago last December. So it's been a pleasure opening up the Houston Neuroscience Brain Center. I also have a company called Clinical Neuroanalytics, where Rusty Turner works with me to analyze these EEGs and quantitative EEG brain maps, and it's been an endeavor to help as many as we possibly can. And we wanted to do this basically just so we can get out and touch people. We find that COVID has really created quite an unrest in the community in a lot of ways. But however, I do think that Zoom has found its way into our lives and into our hearts in its own way. And I think that this is something that's going to be here with us for a long time to come. And so this allows us not to have to get in our cars and drive and meet people, and we can still take our time out. And yet I think the recordings make it nice. So anybody that wants to share this recording with anybody else, please feel free to do so. A little bit about my background. I got my master's and doctorate in social work. I'm the oldest social worker in the world as a brain scientist, published brain scientist. My social work doctorate was more in statistical analyses, and I'd love to do the research. I've got quite a team of young people that are researchers with me, and we are continuing to publish on all sorts of issues. One of the things we're doing, I'm taking part of a 17-site national COVID response to see what kind of changes are going on inside the brain of those who have COVID. We've got a lot of people we've done EEGs on before COVID, and now we can do post on them, but we're looking at collecting about 1,000 plus people in order to figure out exactly what's going on with these brains. And we're seeing some pretty scary things out there right now. So if anybody knows anybody that's got COVID, they're interested, we're looking at least a preliminary signs point towards a direction we can actually bring the brains back, meaning that the cognitive challenges you have may not be permanent after COVID. That's the scary thing for a lot of us professionals out there, because without our brains, we don't work. So that's a big issue right now. And so I'll be glad to take emails, answer questions in that regard and everything else. So with that, I think, let me see what Rusty says. It's saying the host has another meeting in progress. Click the link to registration page. No, but he tried the link, I think, didn't he? Okay, let me send Rusty the link directly. Can you send it to him? All right, guys, hold on just a minute. We need my neurologist in here.
Here, I have his.
Every day you use that.
We send him the link? Okay, he's ready. Okay, we're located at I-59 on Kirby Road, just north of I-59. So we're really centrally located, and it makes it really nice. But let's get Rusty in here, and as soon as he gets here, I'll introduce him. And I really appreciate, we've got 29 in right now. Get it? Okay, maybe too late to do the link.
Yes, again, if you're just joining us, go ahead and put your name and information in the comments to check your attendance for the event. And so we make sure that we send you all the information.
Okay. Well, I'll tell you a little bit about Rusty, and he could show up. He's trying to get logged in now. Dr. Rusty Turner, I met probably in 2016 in Atlanta at a conference we were doing, and we have been collaborating on cases ever since. Rusty's just now checked in, so he's into the meeting now. Hi, Rusty, I'm just now introducing you. He's EEG qualified. He's an electroencephalographer, an epileptologist, a neurologist. He's got all sorts of acronyms behind his name. Very knowledgeable, very energetic, and works a lot just like I do. We go over every case together, so he's my primary go-to neurologist, and he is actually about to finish getting licensed in the state of Texas. So we will have another Texas licensed neurologist that we work with, which is always great to have. So Rusty, would you introduce yourself, please?
Yes, sir. Hi, everybody. Hi, Elizabeth. Good to see you again. I'm sorry for being late. I was playing doctor. I love to say that. Just busy here in the hospital. So I work as a pediatric neurologist and epileptologist. I'm currently helping to fill in at a children's hospital in Omaha, Nebraska, just a little north of you, most of you. And had the pleasure of meeting Ron probably 8, 9, almost 10 years ago, and just expanding what I do outside of, I guess I've always been outside the box. There's so much more to our care than just prescribing medications or avoiding prescribing medications. And, you know, there's just so many cool ways you can learn the brain and understand the brain today, and help kids, which is what I try to do in the hospital as well. So I've been doing this. I mean, I'm back in Omaha. That's where I went to medical school, graduated back in 1984, and back here helping. So I've been around a while and still learning new tricks as the old dog. So, and I apologize for being late. So.
Okay, let's get started with this. I appreciate it, Rusty. And as I'm going through this, Rusty, if you have comments on the PowerPoint points you want to interject, just break right in and let's do this together. I know I sent it to you last night, correct?
Yes.
Right,
Yes,
let me
sir.
share my screen. And this one. Okay. Medication and the brain. I started out many years ago, and Elizabeth, there's two in the waiting room. All right, thank you. And I started doing this probably with Dr. Tarnow back in 2005. I got here in 2003. But with psychiatric medications and medicating children, we're talking about children mostly now, but this applies to adults as well. Rarely does a first prescribed medication, psychiatric medication, work. Rarely does raising the dosage work on the first medication. Thirdly, rarely does a second medication tried worse and most often creates unacceptable side effects. And fourth, by the time the third medication is suggested / tried, parents are looking for other options. So you can put your little hands up and raise whoever's been through this experience. Now the pattern for prevalent pattern for medicating children is, and we have to really, of all the children that I've treated, and it's been in the thousands, and Rusty probably many more, the first thing we usually see it put on a child is they get the diagnosis of an ADHD. It's mostly males, but females also, and they end up putting them on stimulants because that's what Barkley says. Let's put them on stimulants. He's a big proponent of. I saw his presentation the other day at the ADD conference. It was a Zoom conference, but it was a good presentation by him. But that's the go-to, and of course, we're basing the diagnosis on a set of symptoms: the distractibility, the impulsivity, the hyperactivity. And so next, when the stimulants go on at about the age of 6 to 8, then we see that they develop. Once they go through the stimulants, then they'll go into the non-stimulants like the Strattera or the Intuniv to try those in case those don't work. So as they're aging a little bit more and they've got the stimulants on board, it tends to create either an obsessions with them, or anxiety, or repetitive behavior of some sort. And then the antidepressants are the indicated medications for those types of symptoms. And the antidepressants are your Prozac, your Lexapro, your just a whole 17 different antidepressants out there. And lastly, once they start getting into puberty and their behavior becomes more destructive, in a lot of cases, punching holes in walls, having out of control temper tantrums or whatever, then they hit them with the antipsychotics, the Remeron, the Seroquel, and those types of medications. So we have seen multiple times people come into our center over the years, probably hundreds of cases, even 1,000 cases where the children are on at least 3 different types of medications and they're not working well. So polypharmacy rarely works. Okay, now psychiatrists, I am the first proponent of psychiatrists. I think what they do is absolutely magical sometimes. They're doing their best based upon what they have. And what they have is a patient history given by the parents, patient's family history, because that can give them some information, observations of what they see the child doing inside their office, and parent-child reports of symptoms from the parents itself, and then school reports. We all like the school reports. And then at some point in time, they may get psychoeducational testing to refine a diagnosis, especially after the first or second medication. They will often be sent for neuropsych testing for the purpose of refining a diagnosis. So if they have a diagnosis that they may have missed, then they can possibly have another set of medications they can attempt. And then finally, they're the best thing for any psychiatrist to have years and years of experience of doing this. Really tough. Okay, I'm going to put this down. Presenting symptoms equals diagnosis. Okay, I don't think that will. Oh, you did. Good. A medical diagnosis is determining which disease or condition explains a person's symptoms and signs. Now, if I was a man in the mid 1800s and I went into my doctor and I said, "Doc, I'm getting fat, I'm going blind, my toes are tingling. He had diagnosed me with obesity, blindness, and toe rot. But that's not the diagnosis. We didn't have the test, the blood test at that time, to come up with a diagnosis of diabetes. So that's where we are in psychiatry still. We only have symptoms to explain what's going on. And this makes it, this is an issue because there's a lot of diagnoses that share symptoms, and they don't necessarily point us into a treatment. And that's the whole point of a diagnosis, is to lead us to a treatment. The information required for a diagnosis is typically collected from a history, physical examination, and medical tests. We're missing the medical tests. That's the problem in psychiatry. But we have them, but that's why we're trying to get this information out there and having this talk today. Now, being the research nerd that I am, I collect data obsessively and categorize it and get it IRB approved and everything else. In 2013, I had about 386 cases in my data archive. And so I thought, this Dr. Thomas Insel with the National Institute of Mental Health came up and he said that the Diagnostics and Statistics Manual is no longer a valid instrument. It's not a valid instrument. We're no longer going to fund research based upon its categorization. Now, this was a big statement in 2012. It pulled the carpet out from all the psychology and all the psychiatry, because all we have is a diagnosis, and he says it's invalid. So this diagnosis that we have in here, and we collected all these, I had if you're going to do research and run statistical analyses, you have to have big enough numbers. So I combined all the mood disorders into one category. I combined all the anxiety disorders into another. ADHD, I had plenty, and autistic spectrum disorder, I had plenty. So what we were able to identify with all these cases is there was only 4 EEG abnormalities that accounted for all the medication failure cases that we had. And I thought, that's pretty impressive that they did this. I think we should publish something on it. So got a team together and we got this publication out finally. And we'll go over these a little bit here. Encephalopathy. Encephalopathy is a big word that just means, in fact, I'll let the neurologist explain this. Would you explain encephalopathy, Rusty?
Sure, it's if we still remember, I keep it simple, our Greek and Latin roots from growing up in school. Encephalo, again, just deals with the head or the brain, and pathy, meaning pathos, abnormal. It's just a very broad word that the brain is not functioning like it's supposed to. There's many, many, many different causes, and usually the most common ones, and we'll talk about that, and Dr. Swatzyna will do that, is just this pandemic of chronic inadequate sleep and issues like that, which started long before COVID. But that's encephalopathy, just means the brain isn't working right.
Okay, great. And then focal slowing. Focal slowing is something we see pretty commonly in those with learning disabilities. And we can account for all focal slowing. Focal means in one spot only. So part of the brain is slower than the rest of the brain. So this can occur following brain injury, but it doesn't have to always be a brain injury for us to find a focal slowing abnormality. Now, the reason why medications won't work in focal slowing is because you can't tell a medication just go to that one spot and speed it up. So as you start putting on meds, it makes one part of the brain a little bit better while making the rest of the brain worse, to put it simply. Beta spindles, which we're going to call spindling excessive beta, we've had to rename it since I did this study, is a very rare high frequency beta activity that's associated with panic, anxiety, rage events, sleep issues. The first time it was published on was in the 50s, and the second time it was published on was not 2015, when Martijn Arns from the Netherlands and I and Jay Gunkelman and Sebastian Obrecht from Germany, we did this publication on it. We've got a second publication coming out, just submitted it January 1st. And then the last one are isolated epileptiform discharges. And we're going to get into these in depth in just a little bit. So The findings suggest that an EEG provides individualized understanding of pharmacotherapy failures and has a potential to improve medication selection. That was a point right out of our paper. So, and if anybody wants these papers, I'll be glad to send them to you. So the definition of it can be defined as a diffuse disturbance in brain function producing neurological and psychological manifestations. And out of our paper, isolated epileptiform discharges are defined as EEG dysrhythmias identified by episodic paroxysmal, meaning paroxysm is something that we go from a normal background, it explodes, and we go back to a normal background. So it's a paroxysmal burst of slow activity. It's a controversial spike waveform or a true non-controversial epileptiform discharge. So epileptiform is a key word that we're always looking for because this is what brings us into a treatment. So being the numbers person, and Miss Emma Barr is at the University of Texas in a master's program. She's one of my research assistants, and she's the keeper of the archive. And so I said, Emma, please run the numbers on our data archive. We had 1,232 in our data archive, male and female children, adults, and adolescents. And you can see the numbers are quite large, 458. These are all patients of mine. All of their EEGs were read by one single electroencephalographer neurologist. And this is what we found. And I think it's quite phenomenal. I wanted to exclude the focal slowing and exclude the beta spindles from this talk because they could be determined in an actual QEEG. But most of us in doing neurofeedback, we don't do quantitative we do quantitative EEGs to set our protocols, but most in our field do not submit the EEG to a neurologist like Dr. Turner in order to identify these two things that can't be identified in the quantitative EEG brain map. And it's unethical and illegal for somebody to practice medicine without a license. And so as a Ph.D. or a master's level person, you can't identify these and make a report of what you find on this identification you made because this is outside the range of our training. And so that has to be done by electroencephalographer. Every case that I send for the first time always gets an EEG read by a qualified electroencephalographer. Now, you can see in the child females, the 15% of them have that. Now, let me qualify this, this thing that says refractory populations. I know most of you don't know what that means, but I'd like to introduce that word to you. If you have failed 2 to 3 or more medication attempts, then you're called refractory in the industry that we have here. And refractory just means you're not responding to medications typically like we would expect you to. And there can be several reasons for this, but we find that 15% of child females and 46% of 15% have encephalopathy and 46% have isolated epileptiform discharges. And there's rarely overlap, but there can be some overlap between encephalopathy and IEDs. But for the most part, you're looking at 46 plus 15, you're looking at over 50% on every one of these that are having one of these two issues going on. So if your son or daughter or someone you know has been on multiple attempts at medications, you can see even if you're an adult, 10% of the whole adult population, that goes all the way up to the age of 72, I believe, is in our data archive. I'm sorry, 86 now. I just had an 86-year-old. But 43% of them have IEDs, 10% of them have encephalopathy. So this is still something really valid that we want to address here. And I think this one slide alone, we're getting ready to write this up and publish this paper as well. So you're the first one to see this slide on these numbers. Martijn Arns in the Netherlands wants to combine his database, which is also over 1,200, with ours to come up with the numbers on a multi-site study. So I think we're going to do that, and we'll have all that information, and maybe we'll make one of these discussions with Dr. Ron after the fact. Why should EEGs why EEG should be routine in refractory children. And this is something that I like to talk about because neurologists may never see, because IEDs do not produce seizures and encephalopathy presents in children as immaturity. So this is something that that's where they should be seen. But now, and Rusty, as a general rule, if you happen to get a referral from a psychiatrist, and I'm sure that happens, and they have isolated epileptiform discharges, what do psychiatrists who are not into the mindset we have say about IEDs?
There's been a phrase for years, and I don't know if that's what you're getting at, Dr. Ron, but treat the patient, not the test. And so if somebody has an abnormality like a spike during an EEG, which is not a seizure, it's like, well, it's there, but we're going to treat the patient and kind of ignore the EEG.
Exactly right. So it's unless, and this is just a rule of thumb, but people who have higher level training as a neurologist to read EEGs, what we call electroencephalographers, they will call, and they should call, subtle abnormalities like this and let the clinician figure out the value of it. Do we have clinical correlation with it? And so often people say, well, I went to the neurologist and he did the EEG and he said it was normal. And I looked at it and I said, well, yeah, you're not having seizures, but it's not a normal EEG. But that's where the differentiation comes between what the types of EEGs that we want, the types of reading that we want done on our EEGs versus your standard neurology office. And I invited Dr. I don't know if he's in here, if you saw him yet, but one of the other neurologists in our area, I invited him to attend today. I don't know if he's going to, but he probably will look at the tape. And I worked with him for a few years back around 2010. So the other part about this is psychiatrists may never know about these abnormalities unless they order an encephalopathy. They would need to order blood work because the main causes of encephalopathy that we've run across in thousands of cases has been thyroid issues. I found 2 children with Hashimoto's thyroiditis based upon their EEG, and it came back low voltage slow, and they had the signs and symptoms of a faltering thyroid, and it was in the family history. So we got the blood work, and you can't treat a child that's exhibiting ADHD symptoms or mood stability symptoms with a psychiatric medication when their body's not supporting the brain. The thyroid is supposed to support the metabolism going to the brain, and if it's not working, medications aren't going to work. Sleep studies, and Pam has heard me talk about this several times, that I have often run across ADHD children. I had these 2, one 6-year-old and one 8-year-old, and these children were both diagnosed with ADHD. One of the children had actually tried stimulants and had a terrible response to stimulants. And the other child, the mother had seen one of my presentations, I think it was at one of Pam's conferences, and she said, can we do the study before I put my child on a medication? I said, oh, what a thought. What a novel idea. Yes, you can. So we did. And so they both came back with encephalopathy, diffuse encephalopathy, and they'll give me a little hint, possibly having a metabolic, toxic, or anoxic etiology. And I thought this was quite an amazing thing to come back with. And my job is to kind of figure out what direction do we need to go. So when I go down through my list of questions, it seems like both of these little boys had sleep issues. In fact, one of them snored, and both of these little skinny boys, they're not big boys or big thick neck men like me. So we sent them off to get a sleep study. And so they come back, they both have sleep apnea from what they suspect is something that needs to be referred to an ENT, a ear, nose, and throat doc. And we referred him over to him, and I actually invited him to attend this thing today as well. And he said, well, if their tonsils and adenoids are preventing their brains from maturing, and they're only saturating at 94% or less at night, then I'll go ahead and do the surgery. And he did the surgery and took out the tonsils and adenoids on both boys. And I did a 3-month follow-up EEG, and their brains had sped up to normal speed, and their ADHD symptoms had started to abate. So it was just you can't treat obstructive sleep apnea with a medication. You've got to get the airway open, and then and or refer for an EEG. So psychiatrists rarely do this, but this is the program that I'm on right now. We just launched the National Pharmaco EEG program for those that have failed on multiple medications, and where their psychiatrists can order it. And we have people who can collect the EEG data throughout the country, and I'll put them together with the psychiatrist requesting the study, and so that they can upload the data, and then Rusty and our team will look at them and come back with our reports. Now, in regard to the IEDs, they can't be seen on anything but an EEG. Very rarely do we see the traditional, what we call absence seizure indications of staring spells and stuff like that, or twitching of the finger. But they will have, a lot of times, these are the kids that have aggression, panic, uncontrollable emotions, transient cognitive impairment, especially when they miss sleep or they eat a high sugar, high carb intake, and 2 hours later they're just climbing the walls, or they have a lot of stimulation going on, like walking down through the halls of Memorial High School in between classes. I was talking to a young guy about that this morning. So this is something that we definitely would like to be able to know about, because, let me see if I got on the next slide. Because if we know that it's there, psychiatrists know that stimulants, antidepressants, antipsychotics all lower seizure threshold and make the activity worse. So they may need those medications, but you can't use them first line. Obviously, that's why they failed on them, until you put something like an anticonvulsant to actually control them. Now, we did a paper on treating 76 people between the ages of 4 and 52. They were all refractory, meaning they'd all failed multiple attempts at medications. And when we put them on the anticonvulsant, which the studies do say a trial of an anticonvulsant could be considered. Well, we were the first one to publish a study. After doing it, we went back and did a retrospective chart review and found that within the next 3 progress notes, the improvement in their presenting symptoms was 85% improved, 7% stayed the same, 7% had a reaction to one of the anticonvulsants, and we just changed the anticonvulsants. So this is a phenomenal way to get improvement in cases that are terrible cases out there. So Rusty, I'd like you to chime in with whatever just spurred in your mind. I can almost hear you thinking over there. What would you like to add?
I actually was quieting down my thinking and living in the gap, the space between the words, and not getting, any what I call squirrel attacks that I have too frequently. It's good, and what you're saying, on one of your first slides, you said polypharmacy. I don't remember, it doesn't work. And I don't remember if that's how, poly rarely works. And I think right before that anyway. And
there it is.
And I was thinking that's true unless you're God, and I'm not trying to be politically incorrect, but the biggest, most incredible pharmacy in the universe is in us. And when we can change the way we're living, you can help the brain with neurofeedback, kind of the things that you're doing, and helping the brain function better, the chemistry improves. So, because we're on polypharmacy all the time in our bodies, but the natural stuff is better. But getting to that polypharmacy, I saw a 7-month-old this morning in the emergency room who's on 8 different anti-seizure medicines.
Oh my God.
Nobody had talked to the family about nutrition and on, so, and I was just thinking about that too. And I think all in this audience, and I don't wish I knew the background of everybody, And I was looking at the chat there too. I mean, tests are important, but if you go to see a cardiologist, you're having some type of symptoms and a heart doctor put you on this medicine, that didn't work. And then another medicine, that didn't work, another medicine. Well, first of all, they're not going to do that. They're going to do a bunch of tests first, right? Or they won't do 3 or 4 or 5 medicines and go, well, let's take a look at your heart and maybe see what's going on. And yet in our professions, in neurology and psychiatry, how rarely we test the organ that we're actually trying to treat. And so when I see, as what I got behind with today, squirrel, is more seizures happening, but that let's test the organ and use that information, the EEG and the quantitative EEG, to guide treatment. And so, and that's what Ron and many others are doing around the world. Not enough. And certainly it's not a lot of neurologists doing that at this point. I don't know where else to go with that right now, but it just sure makes sense that if somebody comes to see you and they've already been on 3 or 4 or 5 or 6 medications, you know, let's not repeat Einstein's maxim of doing the same thing over and over, expecting different results. Let's pull back, get to the root causes, which is what I know Dr. Swatzyna and team are doing, and I'm sure others of you that are involved in clinical care are doing. So, any thoughts on that, Ron?
No, I just, I had a case that I sent to one of our pediatric neurologists here, and she just sent me an email back. I'm going to forward the email. Alexander treated the young boy. And this was a case where he had encephalopathy. And so we sent him for that's a neurology workup. When he's got encephalopathy, that's outside of psychiatry. That's outside of our practice scope. We got to send him and get a pediatric referral for a neurologist. And so, again, back to toxic, metabolic, anoxic. Well, Dr. Melissa Jones, who's out in Katy, she's excellent. I sent her an invite for this also. She wrote me an email back last night and said that she wanted to tell me how well he's doing. This was her first case she ever found of lead poisoning. This boy actually lives in Galveston, so there's a lot of old homes there with lead paint still. And this boy had also toxic mold in his system. So she's treated people with toxic mold before and everything else. And she was telling me she was at this conference, neurology conference, and found that the inflammation created by toxic mold, that one of the interventions that they were really looking at that helped so much was neurofeedback. And she says, that's the first time I'd heard this, and I think it needs to be brought out there. So I said, well, that's fantastic news to hear, and I will share that, that we can use neurofeedback after the detox occurs and they get the lead out of the person, they get the toxic mold out. How are we going to wire this brain back together? She says this is the fastest, most wonderful improvement she's ever seen in a case that came in that was so difficult, but we did it in a step-by-step procedure, and the boy's been improving ever since. So what I'd like to do now is let's go and how do I get out of this? Stop share. There it is. Okay. Let's take some questions. Anybody have any questions?
Yes, we do have some questions in the chat already started. So I'll go ahead and start with that. Patricia Ali asks, so brain tests, blood work, sleep studies can be ordered, and on a regular basis, they're not being ordered. Is that correct?
It has to be ordered by an MD. I'm a Ph.D. I can't order the test. I can ask that their treating physician order the test. And when I have an EEG report from an electroencephalographer or a neurologist board certified in the state of Texas here, for instance, that is a solid reason to get a test ordered because it's coming from an MD to an MD. So routinely, they're not ordered. Yes, that's true.
Okay, great. The next question is, how do I get other doctors to know this information? My son snores and is a mouth breather while asleep. And I was also told he has nasal airway is blocked 80%. I was told basically, if it ain't broke, don't fix it. Now he's 13 and still snoring.
Well, and I can't ever see a 13-year-old wearing a CPAP. That just doesn't work. I mean, all the way through college, rarely do they wear CPAPs when they should. And so I would say the place to start, let's get the EEG and let's prove that it's affecting his brain. If it's affecting his brain and we can see this encephalopathy and we get a report from a neurologist, then I think that's some power that you have then to go to that doctor or go to, and if we need a referral to an ENT who will listen to this, I have another EMT that will listen to this activity and understand how it can affect the brain. So we just maybe, you need a little more power to go with you other than a mother just complaining, because often that's not taken very well by medical doctors, and that's sad.
Very sad.
And just on behalf of my profession too, it certainly should be. I'm doing 3 or 4 times already this morning working with resident students. Listen to the parents. They tend, or the caregivers, they tend to know. And you hear that story of the 13-year-old, and that ties in with, I think, the previous question, how do you get this information out to clinicians? Well, first they have to be willing to listen, willing to think they haven't learned everything there is to learn. And wow, yeah, just ask for help. And you can do that as a parent or as a clinician. There just has to be that relationship with hopefully a receptive physician that goes, oh, that makes sense. Let's go ahead and order this.
Yeah. I feel really lucky that we live in Houston, so we have access to a lot of choices. But I really feel for families that are in smaller rural areas that might not have the best options in that doctor-parent relationship or caregiver relationship. We have another question. I think it's a follow-up to the one before that. And it says, what do I ask the doctors to order for my daughter? She has ADHD combined. I've been looking for neurofeedback people as well for her and myself. Do you know anything about neurofeedback, Dr. Ron?
Yes, we are up to our ears in neurofeedback right now. No, if any of you want I think my email is pretty, I guess you can give that out at the end of this thing or send it out to everybody on the registration where I can type it right there. Okay, you can type it right there.
Yeah.
So, but I will be glad to discuss this. I live down in League City. I work here at Kirby, just north of 59. And so on my way home, usually about between 3 or 4 o'clock, I'm heading home. I can do phone calls. So I do a lot of my work in that 40-minute drive on the way home. I'd be glad to call and talk to any of you about your particular case and that kind of stuff, and how we can set up a time to get an appointment. And then we got to get the test done.
Yeah.
And that would be the best way to do it, is let's come right here. And so once we have that, then I'll help you work with your doctor, or we can find other doctors. And if it's a pediatric neurologist, I have 2 really great pediatric neurologists, Monica Proud and Melissa Jones here in Houston.
Awesome. And then to follow up to that question, blood test recommended. What was the test for toxins with that little boy in Galveston?
You're going to have to answer this one, Rusty. I don't know. He's still?
I'm not sure. Yeah, I'm here. I'm not sure of the, let me see the
test for mold.
That I don't know. I usually would refer to either an occupational medicine specialist that's more open and understands that, sometimes to allergists, but they typically may not look at that. So I don't know. And I had just one other comment about candy, and maybe you were getting to that, Elizabeth, that had replied before about the septoplasty and all that. I mean, if the pipes are clogged, we got to figure out what's clogging them and how to get them clean. And just talking about ways to clear up. If somebody's got obstructive symptoms like that 13-year-old boy, they need help. It's having such repercussions. And I about 2 months ago, just finished going through a very interesting book that some of you may have read called Breath by James Nestor, Nestor. And it's pretty impressive. I mean, breathing's been around a few thousand years, you know, and the right kind of breathing can make such a difference, even for people that have clogging things. So
Yeah.
I avoided the first question, Ron, and answered another one that people didn't want an answer for.
I think that's a great question, though, and I should know it. So I'll email Melissa and I'll ask her if she can get me that information, so I know at least what parents can be more informed. I'd love to have that. So maybe if we can send that to the answer the question in an email blast afterwards for anybody that may have attended that we don't have the answer. I would always like to get the answer for you. Okay.
Awesome. Well, since Dr. Turner went over the septoplasty question, I'll move to the next one by Laura. It says, my daughter is 22 years. She had been a mouth breather for a long time, but it got worse 2.5 years ago. She dropped her college major to an easier one because she could not concentrate, complained of brain fog, lack of energy, and concentration. I finally took her to an ENT, deviated septum, and sinus were fixed. But I wonder what else health-wise has been affected. What else can I do to help her? I forgot to mention she is on Adderall too and suffers from depression.
Well, just the, again, back to the medication. There's so many kids, college students, taking Adderall, taking a lot of stimulants. And yes, I will have to say truck drivers can drive more if they pump themselves full up of no-dose or, but that's not necessarily what the brain needs. Number one, let's find out what's the brain is asking for. And that's what we do with the studies is number one, we identify what the brain is needing. There's a lot of different reasons, and I gave a talk last time about the ADHD brain, about the different reasons or different underlying neurological abnormalities that can cause ADHD symptoms. If she's on the wrong medicine, that can be contributing to a lot of things. If you're anxious long enough, you become depressed. So that could be all linked together. It could be all what we call in the field iatrogenic caused by medicine. So we always want to rule out first, is she on the correct medicine? And maybe that's contributing. And number two, let's see if we've got any of these isolated epileptiform discharges or encephalopathy that may be contributing. And then what medication may work if there is a medication out there. So we've got to look at that a little bit differently than just looking at her symptoms. But I'd love to see the case. I think it would be a great one.
And if anyone is interested in that talk that we did on the neurological causes for ADHD, it's on our HN Brain Center, Houston Neuroscience Brain Center YouTube, and you can find it there, or we can email it to you.
Great.
Perfect. Yes. Candy asks, does this apply to adults too with brain and toxicity?
Yes, it does. You saw from the numbers, even adults have a high percentage of encephalopathy and of the isolated epileptiform discharges. In fact, a study done out of Europe about 3 years ago linked it to Alzheimer's, these isolated epileptiform discharges, and that they're hypothesizing that if you treat them, even though they don't have seizures with an anticonvulsant, we may be able to slow down or ward off Alzheimer's. So that's the first encouraging thing I've heard on Alzheimer's. But I picked children to focus on, number one, because if at any time somebody would consider spending some money to get this analyzed appropriately, I think it is for their kids. But yes, we see a lot of adults as well, and we run into these same things all the time, obviously from our numbers.
Awesome. And then any doctor recommendations? Melissa Jones, she's a pediatric
Neurologist, right?
neurologist.
Dr. Monica Proud works in Pearland. Melissa works in Katy. Both of them are together in it's one company, but they got two locations. Dr. Rafael Guerrero, I've worked with him with many cases. He's out more towards the Beltway and I-10. And then Diana Collins, Dr. Diana Collins, Dr. Robbie Wright, many of our well-known ones. I'm still working on Aaron Fink. daughter I invited to this, so we'll see. But he's been around a long time.
He's great too. Yeah,
That's great.
he's an OG. Next question is, what all test EEG blood work for neuro issues?
Well, we always want to start with the EEG and the quantitative EEG. That way we can get enough information to know which test then we would go from that point. We don't want to do tests uselessly. And I've had the doctors come back and recommend an MRI. One of the young guys I did an MRI on actually came up that he had no corpus callosum. He was a true split brain. There was no connective tissue between his left and his right hemisphere. That's good to know. And without this test and without the recommendation for an MRI, we would have never known it.
Right. Okay. We've got time for one more question. And this one is from Rachel. Would you consider this a good path for someone who has ADHD and anxiety, cannot take stimulants, and diagnosed with a petit mal seizures?
Perfect case.
Yeah.
Everything that we're talking about, because even if we don't end up going anticonvulsant, neurofeedback was designed in the mid-70s in order to address seizure cases that wouldn't respond to medication. It just takes a little bit longer. There's on YouTube, if you type in Maggie's story, is a perfect example of a little girl that had intractable seizures, and neurofeedback has done wonders for her. So it's something that they should watch. If we can get the rest of the questions we didn't get time to do, if they could forward those to me somehow.
I put the email, it's Dr. Ron at hnbraincenter.com, and you can email us your questions and get in contact with him that way.
I'll be glad to answer them. I'm sorry we're out of time.
Yeah, and it's all just to the last one too, on the seizures. What's neglected even at every hospital I work at is whoever asked the question on the absence, look up MADE, M-A-D-E, Modified Atkins Diet for Epilepsy. It's a variant of the ketogenic diet. Go to the Charlie Foundation website, look for the ketogenic diet. Absolutely, probably 20-30% of the kids and adults I see are on nutritional therapies to help with seizures. So just look that up too, M-A-D-E.
Awesome. Thank you, Dr. Turner. I really hope at the end of this discussion, you really took away something, but the overall aspect of it is that you have two really amazing doctors that are advocating for personalized care and for you to be listened to. And so Dr. Ron and Dr. Turner are exceptional at what they do. And I know that both of them would be happy to answer any questions that you have outside of here. But I love this discussion so much for me. It just is another opportunity for me to be empowered and curious about how to live my best life and healthiest life. So thank you so much to everyone who attended. Again, we will be sending out the slides and the video. If you did not put your name and information in the chat box or registered for the event, there's just no way for us to get a hold of you and to make sure you get the information. So I can't stress enough. I'll keep this open for about a couple more minutes. So if you didn't have a chance to put in your information, please do so we can get this out to you.
And one last word. I just saw one pop up here. The name of our center is the Houston Neuroscience Brain Center. We're at 3730 Kirby. We like I say, you email me. It's Dr. Ron at hnbraincenter.com. I'll be glad to help you out any way I can.
And follow us on our Instagram, HN